Yes, you can literally lower creatinine of 9.1 in 15 days down to 1.67. But here's what almost no one explains about that number. That drop didn't happen because kidney disease reversed. It happened because a different kind of emergency resolved. An international panel called KDIGO, Kidney Disease, Improving Global Outcomes, sets the clinical standards for kidney injury worldwide. They published in Kidney International Supplements in March 2012. Their definition of the most severe category of acute kidney injury, creatinine rising to 3 times your baseline or higher. A reading of 9.1 with a baseline of 1.67 is more than 5 times that mark. That is not a chronic kidney disease number. That is a different medical event. If you're new to this channel, this is where we break down creatinine, eGFR, and kidney numbers in plain language, with the research behind every word. Make sure you subscribe and hit the bell so you don't miss what's coming. Here's what creatinine is. It's a waste product, muscle exhaust. Your body produces it at a steady rate. Your kidneys filter it out continuously. Think of the kidney as a drain running under a sink. In chronic kidney disease, that drain narrows slowly over years. The waste level in the water climbs slightly. A number like 1.67 is that kind of story. A creatinine of 9.1 is not. At 9.1, the drain didn't narrow. Something blocked it. Not over years, in days. The kidneys stopped clearing creatinine not because the filters failed. Something cut off the pressure that runs them. Remove what blocked it. Restore the flow. The creatinine drops, sometimes dramatically, sometimes in 15 days. That's what happened in the story you saw. It isn't a treatment reversing kidney disease. It's the kidneys doing what they're designed to do when the obstacle is taken away. At stage 3 and above, the recovery doesn't always go all the way back. The drain returns to working, but often not quite as wide as before. That matters for how you read your own numbers going forward. The obstacle has a name. Most people who experience this never find out what it was. Some of those names you'd recognize. Some are in your medicine cabinet right now. This is not a diagnosis of what happened to your own kidneys. Bring what you learn here to your kidney team. The goal is a better appointment, not a self-diagnosis. Now, what blocks the drain? There are 5 triggers. We're going through all 5, starting with the least likely to surprise you and building toward the one that drives more emergency creatinine events in people your age than anything else on this list. After that number 1 trigger, I'm giving you something most kidney content skips. What to reach for when you're in pain. And your usual option is now off the table. Real alternatives. Stage appropriate. And after that, the exact words for your next appointment so your risk is in your chart before any of this becomes a crisis. This isn't about what you've already taken. It starts with what you know right now. The first trigger isn't one most people associate with a creatinine spike. It's obstruction. When urine can't leave the kidney because of a blocked ureter, or in men, because of an enlarged prostate pressing against the outflow, pressure backs up inside the kidney system itself. The filter stops working. Creatinine rises. This affects all CKD stages. At stage 3 and above, the kidney's reserve is already reduced. A pressure backup that a healthy kidney might tolerate for days can shut down a CKD kidney much faster. What makes obstruction important is how reversible it can be when it's caught quickly. Remove the blockage. A procedure, a catheter treating the underlying cause, and the filter often resumes. That's a creatinine drop that has nothing to do with diet or protocol. It's plumbing. The practical, pay attention to changes in your urine stream. Volume that's lower than usual. Starting and stopping. Difficulty going. Any change in stream that appears alongside a creatinine rise connects both things in a way your kidney team needs to know. Don't mention one without the other. If your urologist or primary care doctor has mentioned an enlarged prostate, write this down. Any creatinine change alongside a stream change is a same-day call, not a wait and see. You're probably wondering, can kidneys fully recover from a creatinine of 9.1? The honest answer is that it depends entirely on what caused it and how fast the trigger was removed. With obstruction or blood flow disruption, recovery to near baseline is well documented when the cause is identified quickly. But here's what research on AKI outcomes consistently shows. Even a lab recovery doesn't mean zero impact. A review published in Kidney International in March 2012, led by Dr. Stephen Coca at Yale University School of Medicine, analyzed 13 cohort studies and found that patients with a prior AKI episode had nearly 9 times the hazard of developing chronic kidney disease compared to patients who hadn't had one. The drain recovered, but it is not quite the same drain. The second trigger, severe infection. When the body mounts a major immune response to a urinary tract infection, a respiratory infection, or any significant illness, blood pressure can fall. Blood flow to organs drops. The kidneys, which depend on consistent pressure to filter, take an early and disproportionate hit. At stage 3 and above, this matters more than it would in a healthy kidney. The filtering capacity is already narrowed. A blood pressure drop that a healthy person's kidney handles without incident can tip a CKD kidney into AKI territory. This doesn't mean every cold is a crisis. It means that at your stage, a serious infection, one causing a fever over 101, significant fatigue, or any change in urine output, warrants a creatinine check alongside the antibiotic. Not 3 weeks later at your routine appointment, the same week. When you're treated for an infection, let your kidney team or prescribing doctor know your CKD stage. Ask whether a creatinine should be drawn within 5 to 7 days. That one data point can catch an AKI event before it compounds. At your stage, a serious infection means a creatinine check alongside the antibiotic, not 3 weeks later. A nephrology clinic near Tampa, fluorescent lights, paper gown crinkling against the table. She's looking at the lab printout in her hands. Her name is Martha, 68 years old, stage 3 BCKD. Her creatinine at the last visit was 1.8. The number she's holding says 9.1. The nephrologist asks about her medications. She lists them. When she gets to ibuprofen, the doctor pauses. How long? She thinks. 3 months maybe, every day? For my hip. She didn't know. That's the part that matters. Not that she ignored an instruction she'd been given. She'd never been given one. What happened to Martha's kidneys and what brought them back is exactly what we're covering here. The third trigger arrives when you're already inside the medical system. Contrast dye, the agent used to make blood vessels and organs visible in CT scans, cardiac catheterizations, and certain imaging procedures, can directly injure the kidney tubules. It's called contrast-induced nephropathy, and it is the third most common cause of hospital-acquired acute kidney injury. Stat Pearls, the clinical reference maintained for emergency medicine and hospital practitioners and updated in January 2025, puts the numbers plainly. In the general population, the incidence of contrast-induced nephropathy is around 2%. In patients with chronic kidney disease, it rises to 11%. In patients over 60, reported rates run from 8 to 16%. At stage 3B and above, this risk is meaningfully elevated. The question isn't whether you'll ever need a scan with contrast, it's whether your kidney team knows your eGFR before you get one. Before any imaging procedure that might involve contrast dye, ACT with contrast, a cardiac catheterization, an angiogram, your kidney team needs your current eGFR on the order. The conversation is short. I have CKD, stage X. My last eGFR was Y. This procedure uses contrast. What's the protocol? If the radiologist or ordering physician doesn't raise it, you do. Before any scan with contrast dye, your kidney team needs your eGFR first, every time. The fourth trigger is the one that arrives quietly. Dehydration. Not the didn't drink enough water today version, the clinical version. When fluid volume in the body drops significantly, from vomiting, diarrhea, a fever that won't break, heat exposure, or diuretics in a warm month without enough replacement, the blood pressure that drives kidney filtration drops along with it. The drain slows, sometimes it stops. In a healthy kidney, the filter adapts. It can tolerate periods of reduced flow. At stage 3 and above, that adjustment room is narrower. 2 or 3 days of significantly reduced fluid intake or active fluid loss at your stage is enough to produce a measurable creatinine rise. It doesn't require a catastrophic episode. It takes a bad week of stomach flu. Researchers publishing in BMC Nephrology in August 2017, a systematic review and meta-analysis that screened 3,789 papers, found that in older adults, the physiological reserve to handle stressors like dehydration is meaningfully lower, with AKI risk compounding when reduced kidney function is already present. A threshold to carry with you. At stage 3 and above, if you've had 2 or more days of significantly reduced fluid intake, vomiting, or diarrhea, one call to your kidney team. Most of the time, that call is reassuring. Sometimes it catches something that matters. 2 days of significant fluid loss at stage 3 and above, one call to your kidney team, not a wait and see. Before I give you number 1, there's something almost everyone in pain reaches for. Something over the counter, something familiar, something most people have taken for years. After I give you number 1, I'm telling you exactly what to use instead. Options that are confirmed safer at your stage. Here's number 1 on this list. The one most likely behind the story that opened this video: NSAIDs, ibuprofen, naproxen, Advil, Aleve, Motrin. Over-the-counter pain relievers that are effective, familiar, and at any stage of chronic kidney disease, directly dangerous to your kidney's blood supply. Here's the mechanism. Your kidneys depend on a group of chemicals called prostaglandins to keep the blood vessels that feed each filter dilated and open. NSAIDs block prostaglandin production. Without them, those feeding vessels constrict. Blood flow to the filter drops, pressure drops, the filter slows. If you're taking NSAIDs every day for hip pain, a bad back, arthritis, you're kinking that supply hose every day. Researchers publishing in BMC Nephrology in August 2017 ran a systematic review and meta-analysis, screening 3,789 papers and analyzing 10 population-based studies. Their finding, in older adults, current NSAID exposure more than doubled the odds of developing acute kidney injury, an odds ratio of 2.51. In people with CKD individually, studies found the risk anywhere from 1.1 to 5.2 times higher with NSAID exposure. The same KDIGO work group that published the 2012 AKI criteria returned in April 2024 with an updated chronic kidney disease guideline and listed NSAIDs explicitly among the nephrotoxins requiring stewardship in CKD patients. 12 years of guideline guidance. Most CKD patients are still reaching for ibuprofen when their back hurts. At stage 3 and above, NSAIDs are not a safe over-the-counter option, not for a week, not occasionally. A dose that a healthy kidney handles without incident can cause a creatinine spike in a kidney already running on a narrower margin. One important distinction: if you are currently taking a prescribed NSAID for a specific medical reason, do not stop it on your own. That is a conversation with your prescribing doctor. What this covers is over-the-counter NSAID use. The guidelines on that are clear, and the next section gives you what to use instead. The sentence you carry out of this video: ibuprofen and naproxen are not safe pain relievers at any CKD stage. You might be wondering, is ibuprofen really that dangerous if I only take it occasionally? At stage 3 and above, the honest answer is that occasionally is harder to define than it sounds. A dose that a healthy kidney handles without issue can produce a measurable creatinine spike in a kidney already running on a narrower margin. The KDIGO 2024 CKD guideline is explicit. NSAIDs are listed as nephrotoxins requiring stewardship in CKD. The framing is not cut back. The question is, what has your kidney team confirmed as your safe pain option? That conversation takes 90 seconds at your next appointment. The next section is that conversation's starting point. So what do you do when you're in pain? That's the real question, and it's the one most kidney content doesn't answer. It tells you what not to take and sends you home. Here's what's actually available. Acetaminophen, brand name Tylenol, is the first-line alternative for most CKD patients at most stages. It doesn't constrict the blood vessels that feed your kidney filter. It doesn't block prostaglandins. It doesn't cut the supply line the way NSAIDs do. A 2022 study evaluating analgesic options in kidney patients identified acetaminophen as a suitable first-choice analgesic for most people with CKD, with one qualifier. The dose needs to be right for your labs, not right for the box. The box is written for a healthy population. The conversation is short. Tell your pharmacist your CKD stage and ask what your safe acetaminophen dose is. Most pharmacists can answer in under 2 minutes. For musculoskeletal pain specifically, back, knee, shoulder, hip, topical options are worth a conversation with your kidney team. Topical diclofenac gel applies a small amount of an anti-inflammatory directly to a joint, with far less systemic absorption than an oral dose. A 2023 study found that topical NSAIDs carried meaningfully lower kidney risk than oral NSAIDs. Not zero risk, but lower. Some kidney teams approve this for specific patients at specific stages. It's a conversation to have, not an assumption to make. Heat and cold are not glamorous, but they are not nothing. For inflammatory joint pain, 20 minutes of ice reduces the acute inflammation driving the pain signal. For muscle stiffness and cramping, heat increases local blood flow and reduces tension. These work. They have no kidney risk. They don't require a prescription or a pharmacist conversation. Used consistently, they reduce the need for anything else. For chronic musculoskeletal pain, the hip or knee or lower back that has been present for months or years, physical therapy is often more effective than NSAIDs for sustained relief. Not faster, more effective over time. The 2024 KDIGO-CKD guideline explicitly emphasizes non-pharmacological approaches for pain in CKD, including physical activity and PT referral. If you have been managing chronic joint pain with ibuprofen, asking your kidney team for a physical therapy referral is a guideline-consistent request. I've been managing hip pain with ibuprofen. Given my kidney stage, I'd like to explore physical therapy. Can we discuss a referral? Do not stop, start, or change any prescribed pain medication based on this video. What's covered here is over-the-counter NSAID use and the conversation to have with your kidney team and pharmacist about alternatives. The direction is theirs to confirm for your stage. If your creatinine has been going up and no one's given you a clear picture of what's driving it or what you can actually do, we built an entire playlist around that. It's called Lower Your Creatinine Naturally at Home, and it covers this evidence one video at a time. Links in the description. If you're not subscribed yet, now is the time. The next video in that series is already there. There are situations where the trigger isn't something you chose to expose yourself to. A scan your cardiologist ordered, an infection you couldn't prevent, a week of illness where keeping water down wasn't possible. This section is for those situations, not how to avoid the trigger, but how to protect your kidneys when the trigger is unavoidable. 4 protocols, each one short, each one actionable at your stage. Protocol 1, when contrast imaging is medically necessary. Before the procedure, your current eGFR needs to be on the order, not noted from a year ago in your chart, but the current number communicated to the ordering physician and the radiology team before the date is set. If you're not certain it's been sent, call and confirm. I have CKD stage 10 with an eGFR of Y as of date. I want to confirm that's been communicated to radiology. Ask your nephrologist whether a prehydration protocol applies at your stage. For many CKD patients, intravenous hydration before a contrast procedure meaningfully reduces the risk of nephropathy. It's an established practice. It needs to be ordered in advance. It doesn't happen by default unless someone asks for it. After the procedure, the risk window for contrast-induced nephropathy is the first 48 to 72 hours. Watch for urine output that drops noticeably, unusual fatigue, or weight gain from fluid retention. If your kidney team has asked for a post-scan creatinine, get it within that window. Don't let it slide to your next routine appointment. Protocol 2, when a serious infection arrives. You cannot always prevent an infection. What you can do is close the monitoring gap. When you're being treated for a significant illness, at urgent care, an emergency department, or your primary care physician, this phrase changes the outcome. I have chronic kidney disease, stage X, and I'd like a creatinine drawn this week alongside whatever else we're checking. If you're also on an ACE inhibitor, an ARB, or a diuretic, know this. Infection alone can drop blood pressure enough to stress a CKD kidney. Add dehydration from fever and reduce fluid intake, and the combination can move a stable creatinine meaningfully in days. That's not an alarm. That's a reason to check. Protocol 3. When illness causes dehydration, you can't control. Vomiting and diarrhea are not situations where drink more water is always the right instruction. At stage 3 and above, if you've had more than 48 hours of significant vomiting or diarrhea and haven't been able to maintain fluid intake, that's a call to your kidney team, not a waited-out situation. The call is short. I have stage XCKD. I've had 2 or more days of vomiting and can't keep fluids down. I want to know whether I need to come in or what I should watch for. That is a clinical triage question. Most of the time, the answer is reassuring. Occasionally, it isn't. You want to know which. Protocol 4, tell every prescriber your kidney number. Not just your nephrologist, not just your primary care physician. Every prescriber who writes you something. The urgent care provider, the emergency physician, the dentist who wants to prescribe pain medication, the orthopedic surgeon who recommends an anti-inflammatory, the dermatologist who offers a short course of something. Every one of them. The sentence is this: I have chronic kidney disease, stage 10, and my last eGFR was Y. Please verify that what you're prescribing is safe at my level of kidney function. Some prescribers will already know. Others will not ask without prompting. The sentence costs 10 seconds. It prevents the interaction that sends a stable kidney into crisis. One line before we move forward. If you believe you are currently experiencing a creatinine crisis, if your number is known to be rising and you are feeling worse, this is a call to your kidney team today. Not a video to finish first. Everything covered here is protection before the event, not management during one. Here's why the number moved the way it did, and why understanding the difference protects you from misreading your own labs. Creatinine is produced by your muscles at a constant rate, all day, every day. Your kidneys filter it out at the same rate, so the level in your blood stays relatively stable. That's what a normal creatinine represents: production and clearance in balance. When CKD narrows the drain slowly over years, the math shifts slightly, a little less clearance per year. The level in the blood climbs slowly, so slowly that it rarely alarms anyone until it's well advanced. That's the chronic version. In acute kidney injury, something cuts the flow abruptly. Blood pressure dropped from dehydration or infection. NSAIDs constricted the vessels feeding the filter. The filter doesn't stop because the nephrons, the tiny filtering units inside the kidney, were destroyed. It stops because the supply pressure running through them dropped too low to operate. The pipe didn't narrow. The supply line got kinked. When the supply line is kinked, creatinine keeps being produced by your muscles at its normal rate, but clearance falls dramatically, or stops almost entirely. So the level in the blood rises fast, not because there's more waste being made, because there's nowhere for the existing waste to go. Remove the kink, restore the pressure. The filter resumes. The accumulated creatinine, the backlog from the days the filter wasn't clearing, gets processed rapidly. That's the drop. Dramatic. Sometimes within days. This is why a creatinine of 9.1 resolving to 1.67 is not a number that reversed. It's a supply line problem that was fixed. The filter's long-term capacity, the width of the drain itself, was not changed by the event. If there was already narrowing from CKD, that narrowing remains. That's the distinction most viral kidney stories don't explain, and it's the one that keeps the right number from sending you down the wrong path. Take a moment now. Think about the last creatinine number you saw. Was it a stable trend across multiple labs, or did it spike? That question tells you which story you're in, and which part of this information matters most for where you are right now. If this reframes something your doctor never explained, hit the like button. That's how people in the same situation find this channel. Here's the question most people in your situation eventually ask. Why hasn't my own kidney doctor mentioned any of this? It's the right question, and the answer isn't what most people assume. A standard nephrology follow-up runs approximately 15 minutes. In that window, the nephrologist covers the latest labs: eGFR, creatinine, potassium, phosphorus, the trend. They check blood pressure. They review the medication list. They address reported symptoms. They schedule the next appointment. If the numbers are stable, the visit is often shorter. There is no dedicated slot in that template for what are you taking over the counter for pain. There is no checklist item that reads, confirm whether patient knows that ibuprofen is nephrotoxic at their stage. The KDIGO work group published that guidance in 2012 in their AKI guidelines, and the same organization reaffirmed it in their 2024 chronic kidney disease guideline. A patient watching this in 2026 could have had 14 years of nephrology follow-up without once being told not to reach for ibuprofen when their back hurts. That's not negligence. That's a structural problem with a 15-minute window. The average nephrology referral from a primary care physician takes 3 to 6 months to schedule. In that gap, a patient is often managing CKD without a specialist in the loop at all. By the time the first nephrology visit happens, months of potential NSAID exposure may have already occurred, and no one has had the conversation. Once the specialist is in the picture, the 15-minute follow-up template is designed for the highest acuity decisions in the time available. NSAIDs, contrast dye protocols, and dehydration thresholds don't make the cut unless someone specifically raises them. Your nephrologist is not withholding information. They're operating a template that was built for the most urgent clinical decisions in the time available. Everything that doesn't make it onto that template waits, sometimes for years, until it enters routine practice through training updates, guideline revisions, or a patient who walks in and asks. There is also a second lag that sits on top of the first, the gap between a guideline being published and its contents reliably reaching patients in a standard visit. The 2012 KDIGO AKI guidance did not appear in every nephrology visit note that month. Guidelines changed training programs, institutional protocols, and CME courses, slowly over years. The acquittal for your nephrologist is structural. They're not the villain in this story. The system doesn't have room for everything in 15 minutes. But here's what that also means. The only way this information reaches your chart before it becomes a crisis is if someone walks into the exam room and asks. That someone is you. And in a moment, I'll give you the exact words, the sentence that gets your AKI risk documented in your longitudinal record before any of this becomes an emergency. Here are the words. Not a general suggestion to bring it up. Not ask more questions at your appointment. The specific sentences, the ones that work in a 15-minute slot with a physician running to the next room. 3 things to get into your chart. 1 keystone sentence that carries all 3. The first documentation request, your AKI risk factors on record. Most nephrology charts note CKD stage, eGFR trend, medications, and relevant comorbidities. Most do not have a line that reads, patient counseled on AKI triggers, NSAID avoidance, contrast prehydration protocol, and dehydration threshold for calling. Putting that in your chart is a documentation request, not a major clinical intervention. It means the urgent care provider who opens your record before prescribing something sees it. It means the radiologist who receives your referral sees it. It means that if you reach the emergency department with a creatinine spike, the admitting physician has context. The opening sentence, I've been learning about acute kidney injury risk and how my CKD stage affects it. Would you be comfortable noting in my chart that we discussed my specific AKI triggers, NSAIDs, contrast dye, and dehydration, and what I should do if any of those comes up? The second, your safe pain option on record. You now know that ibuprofen and naproxen are off the table, but don't take NSAIDs as not a complete pain management plan. Your chart should have a documented answer to the question, what is the safe over-the-counter pain option at my current stage with my current medications? Acetaminophen is the likely answer for most patients at the dose right for their labs. But the dose right for your labs requires your nephrologist or pharmacist to weigh in, and that guidance should be in your record when you need it, not something you have to reconstruct at urgent care at 9 p.m. The sentence, can we note in my chart what my safe OTC pain option is at my current eGFR, so that's documented if I ever need care from someone who doesn't know my kidney history? The third, Your pre-contrast protocol on record. If you ever need imaging with contrast dye, and at stage 3 and above with the cardiovascular risks that often accompany CKD, it's a realistic possibility. The pre-procedure conversation should already be in your chart, not something you're having in a radiology hallway. The sentence, "If I ever need a procedure with contrast dye, is there a prehydration protocol you'd recommend? Could that be noted in my chart so the radiology team has it?" Now, the 3 doctor response paths. Most nephrologists will engage with all 3 requests without hesitation. If yours responds positively and has clear answers, accept them, ask for them to be documented in your after-visit summary, and leave with something you can reference. If your nephrologist says, "Yes, let's discuss," but doesn't have a formalized protocol, that's a productive appointment. You've surfaced something that goes on to the clinical agenda. Use the keystone sentence to close it. Would you be comfortable noting in my chart that I asked today about my AKI risk, specifically about safe pain options, contrast imaging, and what to do if I get significantly dehydrated from illness? So that's part of my longitudinal record before any of those situations comes up. That sentence does 3 things in one ask. It documents the conversation happened, it names the specific triggers so they're on record by category, and it frames the request as longitudinal record keeping, which is entirely appropriate and which most nephrologists have no objection to. If your nephrologist declines to document it or says they don't see the clinical need, don't argue. Don't show visible frustration, don't threaten to switch doctors. Ask this instead. Is there a better way to flag my AKI risk factors so that other providers who see me have access to them? That question usually reopens the conversation without closing the relationship. The do not do list is short. Don't bring a printout of something you watched online. Don't cite guidelines to your nephrologist. Don't frame this as, "I found out something I should have been told." Frame it as what it is, a patient who has done some thinking and wants their concerns in writing. That framing gets more done in 15 minutes than any other. Do not use this appointment to ask about starting, stopping, or changing any kidney medication on your own. Any medication decision goes through your nephrologist or prescribing physician. What's covered here is documentation of risk and clarification of existing guidance, not self-management of your treatment plan. Never change, stop, start, or modify any prescribed medication without routing that through your doctor first. Sit back for a moment. Picture this: your next nephrology appointment. You walk in with 1 page of notes. On it, 5 triggers, your stage-specific actions next to each, and 1 sentence written at the bottom. You sit down, you know what you're asking. You know what documentation you're requesting. You know which of the 3 response paths you're likely to hear and what you'll say to each one. And when you leave, something is in your chart that wasn't there before, something that protects you the next time you're in pain, the next time you need a scan, the next time you get sick. That's not a medical intervention, that's a skill. The identity that comes out of this is a specific one. The kidney patient who can read a creatinine number accurately, not with fear, not with false reassurance, with the understanding of what is acute and what is chronic. The person who knows the difference between a drain that temporarily got blocked and a drain that's slowly narrowing. The person who knows which triggers to protect against and has that protection in writing in their chart. That skill doesn't belong only to this topic. It belongs to every number on your lab panel. Every time your eGFR moves and you want to know what moved it. Every time a creatinine changes and you need to know whether it's a trend or a trigger. Every appointment where you sit down and need to use 15 minutes, well, the skill is portable. It works for every marker your kidney team tracks. You came into this thinking the story at the start was about a treatment that worked. You're leaving knowing it was about a physiological event that resolved, and knowing exactly what caused it, what enabled the recovery, and what to do so that if it ever comes near your own kidneys, there's a plan in your chart before it gets there. Someone in your life is managing their own kidney numbers without this. They're reaching for ibuprofen, they have a scan coming up and no protocol. They're in the same place you were at the start. The most useful thing you can do with what you've just learned is hand it to them. What makes kidney disease manageable isn't the number. It's knowing what the number is actually measuring. A creatinine that spikes and resolves is a different story from a creatinine that drifts in one direction across multiple labs. You now know how to read both, you know what caused the first one, and you have the sentence that gets your protection documented before it matters. Share this with one person, the person in your life who is managing their own kidney numbers and still reaches for ibuprofen when their back hurts, or who has a scan coming and doesn't know to call their nephrologist first. You know exactly who that is. If the number that has been worrying you isn't a spike but a slow drift, if your creatinine has been moving in one direction across multiple appointments and nobody's explained what that rate of change means at your stage, the next video covers that directly. It's called Video Title. It's on screen now. You came here because a number didn't make sense. You're leaving with the reason it moved and the words to make sure it never catches you without a plan again.